So in the first lecture for our class on diagnosis and assessment, we talked about assessment. In this lecture, we'll switch our focus to the diagnosis piece. And as you listen to the lecture, one of the things I want you to be thinking about is what is your opinion about psychiatric diagnosis. That's something that we'll talk about in class, so keep that question at the forefront of your brain. Now, let's start with a definition. Overall, a diagnosis is the identification of the nature of an illness or other problem by examining the symptoms. In other words, a diagnosis is a system of classifying individuals based on the symptoms that they experience. Now, the important thing to note is that this has been going on for centuries. Just a little vocabulary lesson. The science of classifying abnormal patterns of behavior and experience is called nosology. And the root of nosology can be traced back to Hippocrates, who established a classification scheme that remained influential throughout ancient Greece and Rome. Remember, he was the guy who believed that mental illness was caused by a disease, specifically an imbalance in the four humors. And based on that theory, Hippocrates categorized people as manic or sanguine, having too much blood, melancholic, too much black bile, or hysterical, caused by too much yellow bile. Now, despite the fact that we no longer believe that diseases are caused by imbalances in bile or phlegm or the like, we still, to this day, hold on to a classification scheme that is very much based on a disease model. And we can think of the disease model as a belief system that states that any dysfunction that affects mental functioning can be regarded as a disease. As such, like any other disease, a mental disease can be recognized by specific and consistent signs, symptoms, and test results that distinguish one disease from another. And finally, that once we know what the disease is, we can then specify a treatment. Another name for the disease model is the medical model. And according to the medical model, all mental health symptoms are due to a disorder, and by naming the disorder, we can identify a scientifically based explanation of the disorder that will specify both the cause of the symptoms and the resulting therapeutic actions that should be taken. So in this way, according to the medical model, psychiatric diagnoses serve two primary purposes. One, to provide a language so that clinicians have the same understanding of what a diagnostic category means, and second, to guide treatment. Let's focus initially on this first point, that diagnoses provide a language so that clinicians have the same understanding of what a diagnostic category means. What this essentially means is that psychiatric diagnoses give mental health practitioners a way of talking to one another. They create a shared language. But like most languages, the language of psychiatric diagnoses have changed, at times in drastic ways, over the years. So let me give you a little bit of history. The first edition of the DSM, or the Diagnostic and Statistical Manual of Mental Disorders, was published in 1952. This was after nearly a century of attempts to collect statistical information about mental disorders. This first version included about 106 disorders, which were identified based off of a lot of work that the military was doing throughout the beginning of the 20th century. By the second edition of the DSM, which was published 16 years later in 1968, the DSM now contained 182 disorders, which is a growth of about 71%. And because of when they were published, both the DSM-1 and the DSM-2 were strongly influenced by the psychodynamic approach. As such, all disorders were considered reactions to environmental events as opposed to clusters of symptoms that had biological causes. Like the DSM-1, each disorder in the DSM-2 represented a categorical entity, with diagnosis based on a brief general description. So, for example, the DSM-2 described anxiety neurosis as characterized by anxious overconcern extending to panic and frequently associated with somatic symptoms. Unlike phobic neurosis, anxiety may occur under any circumstances and is not restricted to specific situations or objects. This disorder must be distinguished from normal apprehension or fear, which occurs in realistically dangerous situations. Now, as you might imagine, with descriptions like that, it was actually really hard to figure out how to diagnose someone. It was extremely subjective. As such, the main problem that plagued the earliest editions of the DSM was that it didn't provide an objective or reliable system for describing psychopathology and resulting diagnoses. As a result of this, researchers became particularly interested in developing operational criteria for making diagnostic decisions. And that's exactly what we saw in the next edition of the DSM, which was published in 1980. Not only were many more diagnoses included, from 108 and 80 all the way to 265, but in addition, the DSM embraced a medical model perspective on diagnoses. And that resulted in a movement from general descriptions of disorders to enumerated lists of symptoms that were designed to help practitioners assign diagnoses. More specifically, what we saw in the publication of the third edition of the DSM was that for the first time it provided a definition of the term mental disorders. It presented diagnostic criteria for each disorders, refined a number of major disorders and added a few new diagnostic categories, published reliability data from field trials, utilized a descriptive atheoretical approach, and introduced the multi-axial diagnostic format. Now, the initial version of the multi-axial diagnostic format, which was introduced in the DSM-3, was actually overhauled in the DSM-3R, which was published in 1987. But what we ended up with was a method of diagnoses that was sustained all the way until 2014. And this system of diagnosing was designed to acknowledge a few different things. First, that mental disorders are complex and must be considered alongside physical or other mental conditions, and also that psychosocial and environmental issues can also affect functioning. And while this might not seem like a big deal, at the time the acknowledgement of environmental factors and mental illness was actually a really big change. The other thing that the multi-axial system involved what was called the Global Assessment of Functioning, or GAF. And the GAF was intended to help practitioners describe the severity of symptoms. So the GAF ranged from 100 to 1, with higher scores indicating higher levels of functioning and lower scores indicating poorer functioning. And what practitioners would do would be to subjectively assess the client's level of functioning at the beginning of treatment, and then use the GAF number to track progress over time. So, for example, at the beginning of treatment, I might diagnose my client with GAD, or generalized anxiety disorder, which we'll talk about in a couple of weeks. On axis 2, which is where personality disorders and also cognitive disorders were diagnosed, I could say none. I might indicate that physically my client experiences both hypertension and psoriasis. On axis 4, which was where I could describe social or environmental concerns, I might say that they have problems with their primary support group, indicating that there might be tension or lack of support at home. And I might decide that a GAF score of 55 was most appropriate, which indicates that I believe that they have moderate symptoms or moderate difficulty in social, occupational, or school functioning. And that's what a diagnosis using the multi-axial system would look like. And this multi-axial system of diagnosis was maintained when the DSM was revised in 1994, as well as when the DSM-4 test revision, or TR, was published in 2000. But when the fifth edition of the DSM was published in 2014, we saw huge changes to the structure of diagnoses, as well as what disorders were included. Possibly one of the biggest changes we saw was that, as I mentioned, the multi-axial system and GAF were eliminated. And what that meant pragmatically was that if you take the same multi-axial diagnosis I explained earlier, according to the DSM-5, that would now be written as something like this: moderate generalized anxiety disorder with associated problems of hypertension, psoriasis, and lack of social support. Now, it's not that the information has necessarily changed, because both of these say the same thing, but the presentation of that information is quite different. And believe me, this has resulted in quite a bit of controversy from mental health practitioners, many of whom have been using the multi-axial system their whole career. In addition, the DSM-5 also included a number of additional changes, including changing how disorders were grouped, introducing a new diagnostic category, revising the diagnostic criteria for several disorders, eliminating several disorders and adding some new ones, and creating a way of rating the severity of symptoms, which was intended to replace the GAF rating system that was used in the multi-axial approach. So now, rather than giving someone a number to capture the severity of their symptoms, we instead categorize someone's symptoms as mild, moderate, or severe. Now, before I had said that one of the purposes of psychiatric diagnoses is to provide a language so that clinicians have a shared language they can use to communicate about symptoms, and that is certainly true. But we have to recognize that the language that we use, and as we've talked about before, what we see as abnormal or worthy of a diagnosis has changed dramatically over the years. And in my mind, one of the most painful, harmful, and even embarrassing examples of this is the fact that homosexuality was a part of the DSM-1, 2, and 3 until 1980. And even after that, that ego-dystonic homosexuality, which is a persistent lack of heterosexual arousal, was included until 1987. And so we have to be vigilant about remembering that diagnoses are social constructions, not objective truths that reside within people. And as social constructions, we have to recognize that the language we have developed to talk about diagnoses is seated in our cultural beliefs about normality and abnormality, our prioritization of the medical model, which stresses treatment of disease first and the alleviation of the client's problems in living second, and our healthcare system. Now, it's important for you to understand that I'm not saying that diagnoses are bad. Not at all. In point of fact, I'm someone who believes that psychiatric diagnoses can be exceptionally helpful in guiding treatment. However, even though I believe that, I also think that we have to be thoughtful about the potential pros and cons of diagnoses and the diagnostic system that we've created. So let's talk through some of the strengths of diagnoses and the DSM overall. First, as your book mentions, diagnoses can be extremely empowering for some clients. They can also be helpful in organizing data about clients. We've seen that the diagnostic system we've developed does indeed allow for effective communication among mental health practitioners. It's also increased the efficiency of assessment and screening. And having set diagnostic criteria also makes it easier for practitioners to access research regarding best treatment of particular symptoms or disorders. At the same time, however, the diagnostic model that's used in the U.S. has also been critiqued for a number of different reasons, including that it's based on the medical model, which therefore presumes a particular theoretical stance on how mental disorders are conceptualized, most notably that it presumes a split between the mind and the body. The DSM has also been criticized because the categories are often thought of as mere descriptions that provide no information about dynamics or etiology. The diagnostic categories have also been critiqued as assuming a certain universality of experience, which is ethnocentric or based on dominant cultural norms. Related to this, that our diagnostic system ignores social context and obscures individual differences in client strengths, and overall that it can be pathologizing at times. Despite these shortcomings, diagnoses have, be it for good or bad reasons, become an essential part of mental health treatment in the U.S. and throughout the world. So, as I mentioned at the beginning of this lecture, one of the things that I'd like you to think about in preparation for class is what your opinion is about psychiatric diagnoses. Are they good? Bad? Helpful? Outdated? Think about it, and we'll talk about your opinions in class. See you then.